Good morning, Dr. Lipner. How are you?
Doing great. How about you?
I'm great. I'm great. So glad you're here. I would like to introduce our final speaker. It's Dr. Sherry Lipner. Dr. Lipner is an associate professor of clinical dermatology and associate attending physician at the New York Presbyterian Hospital at the Weill Cornell Medical Center. And I'm looking forward to your presentation. So I'm just going to turn it over to you. Kick it off.
Thank you so much for inviting me to speak today. And I'm really thrilled to be here giving you my talk on onychomycosis in special populations. And today we'll focus on two sets of populations, patients with peripheral neuropathy and those with vascular disease. These are my conflicts of interest. The only relevant one is that I serve on the advisory board for orthodermatologics, which makes the drug efinaconazole, which we'll speak about in the treatment section. So as you know, onychomycosis is the most common nail disorder that we see in clinical practice, about half of what we see. And it goes well beyond aesthetics. It has a significant impact on quality life. Patients have trouble doing their daily activities. Their toenails can be painful and there can be secondary infections. Prevalence is high globally and also in the United States. And there are many known risk factors, and these include trauma, diabetes, immunosuppression, tinea pedis. And we'll talk specifically about vascular disease and peripheral neuropathy and how they relate to onychomycosis today. So let's first start with the diabetic population because we know that these patients have high incidence of both vascular disease and peripheral neuropathies. So what is the pathogenesis with onychomycosis? Nail proteins in diabetes patients are highly glycosylated. Glycosylation promotes nail infections, and also diabetic neuropathy impairs nail growth, leading to gait disturbances and neuropathic ulcers. Capillary glycation leads to vascular disease in diabetes patients. Vascular disease decreases nail circulation, causing gait disturbances and plantar neuropathic ulcers. Now let's look at a few studies. So this was a study by Gupta and colleagues, and they looked at 254 patients at a vascular clinic, and about a quarter of these patients had onychomycosis. And they looked at various risk factors related to onychomycosis, and one of these was peripheral arterial disease, which they measured using the ankle brachial index, and they defined peripheral arterial disease as those patients with an ABI less than 0.8%. And they found that onychomycosis was much more common in the patients with peripheral arterial disease. So it may be an earlier onychomycosis may be an early marker of peripheral arterial disease, and also peripheral arterial disease may make patients more susceptible to getting onychomycosis. Sorry, I'm just having trouble advancing the slides.
Just Dr. Lipner.
Yes.
You can see your PowerPoint on your computer, right?
I see it, but now I have like this big screen also, and it's not advancing for some reason.
On your computer, it's not advancing?
I think it's in like a different view right now. Let me just stop my screen share for a second and restart it.
That's fine. See if that comes back up because it was working here.
Okay. Okay, it's working now, I think, again. So this was another study, and this looked at, it's a study by Kulak and colleagues, and they looked at venous insufficiency, and they measured this by Doppler ultrasound, and they also used the Valsalva. And what they found was that venous insufficiency was more common in patients with onychomycosis, so about 35.7%, versus controls, where it's only 15%. So let's talk about the pathogenesis of onychomycosis. Most of these infections are due to dermatophytes, particularly Trichophyton rubrum, and next most common is Trichophyton metagrophytes. Then about 20% are non-dermatophyte molds, and then the rest are yeast. There's also evidence that there may be mixed infections, so perhaps a dermatophyte with a non-dermatophyte, dermatophyte with yeast. And there is a role for biofilms being important in the pathogenesis, and these are fungal hyphae surrounded by an extracellular matrix. So it may make it harder for some of these medications to penetrate these biofilms, and this may account for some of the treatment failures. Now, let's speak specifically about the diabetic population. And this was a study by Gupta, published in the JEADV in 2015. Their group did a systematic review looking at pooled prevalence estimates of onychomycosis. So in the general population, the prevalence of onychomycosis was 3.22%. And if we look specifically at yeast causing these onychomycosis infections, this was highest in the elderly, and the second most common population to have yeast were diabetics. So it's important to note that diabetics may have different organisms than the general population, and that may affect our treatments. So what is the clinical presentation of onychomycosis? Well, you look for onycholysis and subungual hyperkeratosis, which is scale beneath the nail plate. And there may be accompanying plantar scale or interweb scale, and that may be a clue to the diagnosis. These are other pictures of patients with onychomycosis. You could see here how thick the nails can get. There may be accompanying hematomas, just because the nails are thick and they're more prone to trauma. It often involves all the toenails. Here's another case. Not as severe as the previous one, but you see these streaks, this yellowing, subungual hyperkeratosis. Now, this is a family that came to me. This is the nails of a father, and this is the nails of his son. And it just shows you that with onychomycosis, it's like a scabies phenomenon. So once someone in the household gets it, it's very likely that the rest of the family will also get it. So it's important to treat not just the person coming into the office, but to ask whether anyone else has problems with their nails or scale on their feet, and it's important to treat the whole family, or it just keeps bouncing back between everyone. Now let's look at some less common clinical presentations, and one of these is a dermatophytoma. And this is defined as a fungal abscess, so the hyphae are densely packed, and traditionally these have been harder to treat than regular onychomycosis. And they present with either a streak, a yellow streak, or a white streak, or a patch in the nail, and that's a clue that this is a dermatophytoma. And if you were actually to do a clipping on this and send it to your dermatopathologist, you would be able to see these tightly packed hyphae. This is an example of fungal melanonychia. So a clue that this is fungal is that it's wider distally and tapers proximally, and this is due to Trichophyton rubrum. And then there's the proximal subungual subtype, where the fungus invades near the cuticle as opposed to near the hyponychium, and these are generally harder to treat than the distal subungual types. Now, dermoscopy can help you in making the diagnosis, and you may see a fringed proximal border near the area of onycholysis, and you can also see these longitudinal striae, and here you can see yellow ones, but they can be mixed with different colors such as orange, black, or brown. Now, it's important to differentiate onychomycosis from other nail infections. And this is an example of a patient with a Pseudomonas nail infection. And Pseudomonas aeruginosa makes two pigments, pyuverdin and pyucinin, so it gives off a blue-green hue. And this is common in patients that are exposed to a lot of water, such as scuba divers or swimmers. And this, of course, is an acute paronychia, acute bacterial paronychia, and of course, these are treated differently than onychomycosis. Inflammatory nail conditions can also resemble onychomycosis. So this is a patient with psoriasis. You can see how thick the nails are and how difficult it would be to do anything with these nails. Here you can see the pitting of onychomycosis, so little indentations in the nail. And here you can see onycholysis, which this is psoriasis, but you can also see this in onychomycosis. And this is an example of lichen planus, where you can really get loss of nail, and it can resemble the end stage of onychomycosis where you get crumbling. So onychomycosis also has to be differentiated from inflammatory nail conditions. These are some other nail conditions. So these are both degrees of cessation of nail growth. This is an example of onychomycosis. This is an example of retronychia, looks very similar to onychomycosis. This is congenital malalignment of the great toenail. Typically, we would see this in kids, but we can see adults that have acquired forms. And this is an example of onychogryphosis. These are two examples of subungual exostosis. So this patient, I thought, had either congenital malalignment or retronychia, but an X-ray showed that this was a subungual exostosis. And this is a child with a more typical looking subungual exostosis. Chemotherapy can also induce paronychias that can resemble onychomycosis, and this can be due to some of the tyrosine kinase inhibitors. Benign nail tumors can also be mimics for onychomycosis. This is an example of a patient with a verruca. This is a patient with a glomus tumor, and this is a patient with an onychomatrachoma. Malignant nail tumors can also resemble onychomycosis. These are three different examples of nail unit squamous cell carcinoma, one presenting with a cutaneous horn, one with this split, and you can see here erythronychia, and here you can see onycholysis, and you can see that there's a mass under the nail here. Melanomas can also resemble onychomycosis, particularly the fungal melanonychia, and these are all cases that were biopsy-proven nail unit melanomas. In this case, you can see that there's a Hutchinson sign, so there's pigment that's also on the skin. This nail has various degrees of onychodystrophy, including splitting, as well as this nail. Nail unit metastases, these are quite uncommon, but they can resemble infectious nail diseases, and this is a metastasis due to renal cell carcinoma. So I think in the previous slides, I showed you why we really need to prove the diagnosis. And I'll just try to hit it home a little harder here. So these are three examples of patients that all look like they have onychomycosis. This patient has proven mycological onychomycosis. So if we were to treat this patient with an antifungal, this patient would get better. This patient has psoriasis. So if we were to treat this patient with an antifungal, this patient would not get better and would likely get worse. And this patient has a squamous cell carcinoma, and if we were to treat this patient with an antifungal, this really could have terrible consequences. So there are many methods to make the diagnosis. They each have their pluses and minuses, and I'll go over these today. So you could do a KOH with microscopy, and one of the advantages of this technique is that it's incredibly inexpensive. However, it is expertise dependent, so if you haven't done a lot of these during residency, it's pretty hard to be good at it. It has low sensitivity, and you don't know the viability or identity of the organism. Fungal culture, and this is an example of a T. rubrum culture, was long considered the gold standard for diagnosing onychomycosis. And the reason being is that you know both the viability and identity of the organism, but it can take several weeks for results, and we know that our patients want to get treatment immediately, and there's a high false negative rate that's very lab dependent. I really like histology, so taking a clipping and sending it to the pathologist, because it's rapid, it's sensitive, you can diagnose other nail diseases such as psoriasis, but you don't know the viability or identity of the organism. Now, molecular biology is readily available now, and it's increasingly being used for diagnosis of onychomycosis. Results are within 24 to 48 hours, and it has a high sensitivity and specificity. And in this DNA gel, I'm showing you here in lane 1, a DNA ladder. In lane 2, this is a band corresponding to trichophyton rubrum. In lane 3, you see both trichophyton rubrum and candida. And in lane 4, this is a control. So it does show you the identity of the organism. It does show you mixed infections. Negatives are you don't know the viability of the organism, and if you don't clean carefully, there can be contaminants. Now, it's very important to know how to sample the area. So patient sent in samples are really not good. Patients don't know how to sample their nail. Also, their nail clippings would be sitting for a long time, so this could inhibit the viability of the organism. But you want to clip the most proximal oncolytic area, so the area that's lifted, and you want to go back as far as you can because this is the highest yield if you're doing histopathology. Now, if you're doing culture or PCR, what you really want is subungual debris. So after carefully cleaning the nail with soap and water, and you want to do this to avoid contaminants, you clip back the nail, and then I use a number 1 curette to gently scrape the subungual debris from under the nail. And if you use a black background, you can really see how much you're collecting so that there's a contrast between the paper and the scale that you're collecting. Now, this is not ready for use, but artificial intelligence is being used in podiatry, and for onychomycosis, it's no exception. So this was a study by Kim and colleagues of 90 patients where photographs were taken by research assistants. And the ground truth was determined either with KOH with microscopy or with culture. And they compared the ground truth to 5 board-certified dermatologists making the diagnosis clinically and 2 board-certified dermatologists making the diagnosis with dermoscopy. And here we're looking at receiver operating curves, and you can see here that the algorithm is equivalent to dermoscopic exam, and the algorithm is also non-inferior to the dermatologist. Now, this has also been done with dermoscopy. So in this study by Zhu published in Mycoses this year, they took over 1,000 images of onychomycosis, nail psoriasis, trauma, as well as normal nails. And they found that jagged edge, longitudinal striae, cone-shaped keratosis, marble-like turbid area, and distal irregular termination were all very sensitive for diagnosing onychomycosis and beat physicians in making the diagnosis. So artificial intelligence is also being used to diagnose onychomycosis using dermoscopy. And this also applies to glass slides with clippings from nails with onychomycosis. So in this study by DeCreux and colleagues, they had 200 samples, 100 were confirmed onychomycosis, and 100 were normal nails. And you can see here that the dermatopathologist 1 and 2, who were more senior, versus dermatopathologists 3 and 4, which were less senior, 1 and 2 had a higher sensitivity and specificity than the algorithm. However, it really was very close between the algorithm and the dermatopathologists. But some negatives to this artificial intelligence exam was that there could be false positives, such as serum, nail fragments, bacteria, and neutrophils, and also false negatives where there are a few hyphae or cross-cut hyphae. So I don't think we're ready to use artificial intelligence either clinically or by dermoscopy or for pathology images yet, but this may be something that we will be using in the near future. Now, what about treatment? So there are certain treatment considerations, and that is elimination of the infecting organism, and the other is nail growth. So we have to note that for toenails, it takes a year to a year and a half for them to grow out. And in the elderly, this can be a longer process than in younger individuals. So typically, for courses with these onychomycosis drugs, we're talking about 1 year for topicals And for orals, generally it's for 12 weeks. So there are certain definitions that we need to understand so that we can understand these clinical trials. And the first is mycological cure, and this means there's a negative KOH and a negative fungal culture. The second is clinical cure, which is a completely normal-looking nail. And the third is complete cure, which is a combination of mycological and clinical cure. And this is what the FDA requires in letting these drugs be approved for use for onychomycosis. So there are only 3 FDA-approved topicals to treat onychomycosis. So if a patient is coming in using tea tree oil, Vicks VapoRub, those are not have ever been studied. Actually, Vicks VapoRub has been studied in a small trial and does not work for T. rubrum, does work a little bit maybe for T. mentagrophytes. But these are the FDA studied ones. And so cyclopirox 8% solution was first approved back in 1999. It's a hydroxypyridone, and its mechanism of action is not completely understood, but it's thought to inhibit cytochromes and also affect protein and nucleic acid synthesis. It wasn't until 15 years later that we had 2 new FDA-approved topicals, and that was in 2014. So the first is efinaconazole 10% solution. This is an azole, and it works in the ergosterol biosynthesis pathway, inhibiting 14-alpha demethylase. And the third one is taboberol 5% solution, which is a benzoxaberol, and it has a novel mechanism of action inhibiting specifically fungal but not human aminoacyl tRNA synthetase. So let's look at the courses and the cure rates for these drugs. So for all of them, they're applied daily for 48 weeks. And in the clinical trials, they then had a 4-week washout period and looked at mycological and complete cures at 52 weeks. So for cyclopirox solution, mycological cures were 29 and 36%, and complete cures were 5.5% and 8.5%. For efinaconazole solution, mycological cures were 53.4% and 55.2%. Complete cures were 15.2% and 17.8%. And taboberol solution, mycological cures 31.1% and 35.9%. And then for complete cures, it was 6.5 and 9.1%. So it's important to note that these clinical trials were not head-to-head, so we can't directly compare one to the other, but we can see that for some of these newer medications, it does look like mycological and complete cure rates were higher. So now let's look at the systemic medications. There are only 3, and one of them is griseofulvin, but I don't have it on this chart because it's rarely used these days because we have better, more efficacious options. So there's terbinafine, and this is an allylamine, and it works in the ergosterol biosynthesis pathway, inhibiting squalene epoxidase, and it has very good coverage of dermatophytes, a little less so for the non-dermatophyte molds and candida. Then there's itraconazole, and like the other azoles, it inhibits 14-alpha demethylase. It does cover dermatophytes, maybe not as well as terbinafine, but it has better coverage of non-dermatophytes and candida. Now, I do want to mention fluconazole. It's used off-label in the United States. It's not FDA approved. However, it has been studied in clinical trials. It is approved in other countries, such as Europe. And it has the same mechanism of action of itraconazole and also very similar coverage to itraconazole. Now, both itraconazole and fluconazole have many, many drug-drug interactions. Terbinafine has very, very few. So often, if patients are taking multiple medications, terbinafine is a lot easier to use. Fluconazole has an advantage over itraconazole in that it doesn't have the cardiac side effects. So often, this is just easier to give. We don't have to check with a cardiologist, and patients may be more open to using fluconazole versus itraconazole. Now let's look at the cure rates for these drugs and the courses. So for terbinafine, it's given daily for 12 weeks. I should mention that there are pulse doses, but the FDA approved dose is for daily for 12 weeks. For pulse dosing, some people do a week per month, but there are various other pulse dosings. Mycological cure in the clinical trials was 70%, and complete cure was 38%. Itraconazole is given the same way for toenails. It's daily for 12 weeks. Mycological cure 54%, complete cure 14%. And for fluconazole, it's actually dosed very differently. So it's given weekly, once a week, until the nail grows out. So generally about a year for the toenails. And so this may be harder to do for some patients because it's hard to remember to take a pill once a week, so you can tell them to put a reminder on the phone. And the mycological cure was 37%. Now, a lot of patients come in, they want the topical antifungals. They're very nervous about the oral antifungals, but let's talk about what the indications are. There are no strict indications, but these are the ones that are generally accepted. So patients do well who have superficial onychomycosis because the fungus is more on the surface. And some cases of distal lateral subungual onychomycosis, such as ones where less than 50% of the surface area of the nail is affected, no involvement of the lunula, and a thickness less than 2 millimeters. You can use topicals in patients with up to 3 or 4 nails affected. Those patients with contraindications to systemics, such as those who are liver transplant recipients. And these medications, especially efinaconazole and tavabarol, are approved for children 6 and up. And the advantage of using them in children is that their nails are thinner and they grow faster, so they tend to work well in children. Now, they are being considered in combinations with systemics, and we'll talk about it in a little bit, and they can also be used in combination with debridement. There's been talk about using them for prevention of recurrences, but there really isn't any on that. Now, who are the patients you really shouldn't use topicals for? So you shouldn't use it for patients with proximal subungual onychomycosis because these patients probably won't do well. Those patients with distal lateral subungual onychomycosis where more than 50% of the surface area of the nail is affected, a thickness more than 2 millimeters, and those with more than 4 nails affected. So here you can see this patient has all toenails affected as well as one hand with the fingernails, and this is called 2-foot 1 hand onychomycosis, and these patients generally do better with oral. Patients also can't use topicals who have poor visibility. They won't be able to see putting it on, poor flexibility. They won't be able to bend over to put on the topical to their toenails, and those with poor dexterity. Topical therapy also may not be good for patients with poor prognostic factors, and some of the patients that fall into those categories are those that are immunosuppressed, those that are diabetics who also may have vascular disease as well as peripheral neuropathy, and we'll get into that in a little bit. Now, with topicals, it's really important to explain to the patient, take the time, how to apply the medication, because it's not necessarily intuitive. So with cycloperox, the medication is applied daily to the toenail, and then the patient needs to clip it weekly and then needs to come in to see the podiatrist for monthly debridement, sorry. And so the medication also has to be removed weekly. So this is a patient who came to see me, had previously seen another dermatologist, and was just applying the cycloperox and applying the cycloperox and applying it and never took it off. And you can imagine that the penetration would be pretty poor in that case. And here I actually tried to, wipe off as much as I can of the cycloperox, and you can see the nail looks completely different. Now, tavabarol and efinaconazole are applied a little bit differently. So with efinaconazole, the medication is applied to the nail the proximal nail fold, the lateral nail fold, and the hyponychium, but it does not have to be removed weekly and doesn't have to be clipped or debrided. And with taboberol, it's just applied to the nail plate and the tip of the nail, but not to the nail folds, and also no clipping or debridement necessary. So let's talk a little bit about terbinafine, because patients, I'm sure, coming to you are very, very nervous about terbinafine, about the side effects. They're all convinced that it's going to kill their liver. We actually wrote a paper about this fear factor with terbinafine and looked at what was on the web, and there was really very unreliable information there. So let's look back at the original clinical trials and what the side effects were. So when we look at the terbinafine group versus placebo, the prevalence of transaminitis in the terbinafine group was 3.3%, and in the placebo was 1.4%. And if we look at the prevalence of smell and taste disturbances in the terbinafine group, it was 2.8% and 0.7% in the placebo group. So relative to placebo, smell and taste disturbances were actually more common than transaminitis. And this is something that patients don't even know about. So it's important to counsel them on potential side effects, especially smell and taste disturbances. I have seen a few cases of them. I will say that I didn't warn one of my patients about this when I first started out, and she was pretty mad at me. She was pretty upset. Luckily, her taste did come back. But in light of the fact that COVID-19 can also cause these smell and taste disturbances, I think it's important to counsel patients about it. And we also looked at the FDA Adverse Event Reporting Database, and this is a database where patients can report their side effects, pharmaceutical companies can report their side effects, and then any clinician can report side effects. And there were similar results compared to the clinical trials. So the most common side effect was actually smell and taste disturbances, and in the database, it was about double of transaminitis. So again, important to counsel patients about this. Now, what about lab monitoring with terbinafine? So this is a question we wanted to ask. So we did a retrospective study on almost 1,000 courses of terbinafine for onychomycosis. And like the clinical studies, we saw that there were very few monitoring transaminase elevations. And we similarly looked at CBC abnormalities, and they were also uncommon. We saw that none of these elevations or abnormalities were severe. There were no grade 3 or 4 changes. And so we concluded that interval monitoring is likely unnecessary in healthy adults. However, we did see more of these changes in patients who were over 65 and also those with comorbidities, including diabetes. So it may be prudent to do monitoring in patients in these groups. Now let's talk a little bit about adverse events with topicals. I mean, the good thing about topicals is that we don't really have to worry about systemic side effects, and so the conversation with the patients is a lot easier. But when we look at the clinical trials with cyclopirox, efinaconazole, and taboberol, our 3 approved onychomycosis drugs, side effects were pretty similar. So some patients got application site reactions. There was ingrown toenail that was common in all of these cases that resolved as the nail grew out. With cyclopirox, you can get some nail plate discoloration. Taboberol, there were some reports of dermatitis. But with efinaconazole, there were several reports of allergic contact dermatitis, and this is an example of a patient from a paper by Hirota and colleagues in contact dermatitis from 2015, so shortly after the drug was FDA approved. And these patients can present with your typical contact dermatitis with poison ivy-like reactions with these vesicles, and it can be incredibly itchy. So important to warn patients about it. And I've seen a few cases, and it really is intolerable for the patient to continue if they do get this. Now let's talk about treatment in these special populations, such as those with chronic venous insufficiency. And so this was a study published by Avner Shemer, who works in Israel as a nail specialist in the JEADV in 2008. And they looked at 44 patients with chronic venous insufficiency, 28 of them had onychomycosis. And these patients were all treated with itraconazole pulse therapy, and they found that the total cure in this population was only 25%. Only about a quarter of these patients had a complete cure, and there was absolutely no improvement in 58% of the patients. And you can see this in this figure over here. And so the patients with chronic insufficiency at baseline had a higher rate of nail deformity. So, and they may have thicker nails. So when we counsel our patients with chronic venous insufficiency, even if we're giving them a drug that we think is efficacious, such as an oral drug, they may get a mycological cure. So when we sample their nail, we may find out that their fungus is gone, but their nail may look better, but it may not look completely better. So it's important to counsel patients on reasonable expectations. Now let's also look at treatment of diabetics who have a high incidence of peripheral neuropathies and vascular disease, and treatment with efinaconazole. And this was a small study by Schaffler and colleagues published in the Journal of Clinical Podiatric Medicine and Surgery in 2020. They looked at 40 patients with onychomycosis, and the average hemoglobin A1C level was 7.71. And they found that the complete cure was 11%, and the mycological cure was high at 58.33%. And these are examples of patients in the study where you can see what they look like initially and what they look like after full treatment. And they found that the glycemic control, it didn't matter about the glycemic control, there was the same outcome in these patients, and the drug was well tolerated. So even in diabetics where it's thought to be a poor prognostic factor, efinaconazole certainly can be considered as one option. So this was a better study. This was a larger study, and there's also placebo. And this was a study by Tracy Valhovic and Warren Joseph, published in the JDD in 2014. And so this was a post hoc analysis. So this wasn't the original trial endpoints, but they studied a small subset of patients after the phase 3 trials. And there were 112 patients, age ranged 29 to 70 years. Patients were treated for 48 weeks like the original clinical trials. They then looked at the patients at 52 weeks. Patients were randomized either to efinaconazole solution or placebo. And the mycological cure with efinaconazole in the diabetics versus the non-diabetics was basically the same. And the complete cure looked like it was a little lower in the diabetics versus the non-diabetics, but the difference was not statistically significant. So again, a study showing that efinaconazole can be used in the appropriate patients with diabetics. Now, what's on the horizon for treatment of onychomycosis? There's terbinafine 10% solution. This was studied by Dr. Gupta in a phase 3 clinical trial with patients with distal lateral subungual onychomycosis. There were 365 patients in the study. Again, the drug was applied for 48 weeks. Patients were assessed at 52 weeks. So what happened? Complete cure rate was 4.5% with drug versus vehicle. Mycological cure was much better, about 70% versus 28% with placebo. And so why is the mycological cure rate so high and complete cure rate so low? And this is because of the vehicle itself. So it gives this opacity to the nail plate. So the drug does seem to work, but it discolors the nail somewhat. So we'll see what new clinical trials have to show on this. There are also some new oral antifungals on the horizon. So posaconazole is FDA approved, other indications not for onychomycosis. And in a phase 2B trial, if we look at both the 200 milligram per day 24-week time course and the 400 milligram day 24-week time course, these exceeded the mycological and complete cure rates for terbinafine at 12 weeks. There's also fosrabiconazole, which is approved for toenail onychomycosis in Japan, but not in the U.S. And you can see here that the complete and mycological cure rates, 59 and 82%, were much higher than placebo. And finally, there's oteseconazole, which is being studied but not yet FDA approved. Very high complete, 41 to 45% complete cure rates, mycologic 65 to 75% cure rates. So there may be some new azoles that are coming to town, hopefully in the next few years. Now let's spend a few minutes talking about devices to treat onychomycosis. There are various devices. There are several advantages to them, and that's improved efficacy because the podiatrist is doing it. There would not be any systemic side effects since this is a local treatment, no drug-drug interactions like the systemics, no need for laboratory monitoring, few contraindications, minimal adverse events, and of course, because the podiatrist is doing it, there's improved compliance. So we should note that lasers are not first-line treatment for onychomycosis therapy, and that's because the FDA approved them only for temporary increase of clear nail, not a cure, and the FDA requires less stringent endpoints for device approvals. So Dr. Gupta put together this nice study in the JEADV in 2017, looking at average mycological cure rates using patients as the unit of analysis, where it was only 11%. And then if we use nails as the unit of analysis, it's 63%. Average clinical cure rate only 13%. So not great data there for lasers. This is a study published by Mutran, a case report in the JEADV. This was a 64-year-old woman treated with onychomycosis. She was treated with diabetes 11 years prior and a diabetic neuropathy 4 years prior. And she was treated with an Nd:YAG short pulse laser, and this resulted in necrosis of the great toe requiring amputation. So this is just to beware of using laser treatment in diabetics with peripheral neuropathies because often they can't even feel the pain. So beware of using lasers in this population. There are other devices that have been tried. So we used a plasma device for treatment of onychomycosis with moderate efficacy. There's also a microclipper, which basically uses a device that drills holes that are less than the width of a hair, and then in conjunction applying a topical with it. And here's a picture where you can see that this patient is in the middle of treatment, but you can get pretty good efficacy with this microclipper device. Now, what about combination treatment? This is popular amongst dermatologists. I'm not sure, podiatrists are doing this combination treatment. So we looked at the studies with combination treatments. And so with medication combinations, there were conflicting results, small sample sizes. Medication and laser did not really show any benefit. There was no long-term follow-up. So our conclusion from this paper was that combination really should only be considered in patients that fail appropriate FDA-approved monotherapy or patients with poor prognostic factors, but really shouldn't be given for most patients. So what about prevention of recurrences? These are quite common with onychomycosis, and there are certain things we can counsel patients about, such as avoidance of occlusive footwear, treating infected socks, avoidance of nail trauma. And I do really like this study by Schemmer, published in Derm Therapy in 2017. And these were patients that were treated with either terbinafine or itraconazole for their toenail onychomycosis. And patients either used a weekly prophylaxis with an antifungal to their feet or didn't use it. And they found that the recurrence rate was threefold lower in patients that did use prophylaxis. So part of my thing is after I treat the patient with an appropriate either topical or oral antifungal, I make sure that they use a topical antifungal to their feet on a daily basis. And with that, I hardly ever see recurrences. And if I do, it's usually for patients who were not compliant with the therapy. I also use a lot of telemedicine for onychomycosis. And so it's not appropriate for a first-time patient. But once the patient's mycologically confirmed, it's great for initiating treatment, monitoring response to treatment, explaining and demonstrating how to apply topicals, and counseling on prevention of recurrences. So take-home messages today are to describe the clinical findings of patients with onychomycosis. We spoke about onycholysis, sublingual hyperkeratosis, accompanying tinea pedis, forming a differential diagnosis for onychodystrophy. So knowing that half of what we see in podiatric practice is going to be onychomycosis, half is not. And we want to make sure we're treating patients for onychomycosis who actually have onychomycosis. Confirm the diagnosis before treating for onychomycosis. You have KOH with microscopy. You have fungal culture. You have histology. You have PCR. And we may have artificial intelligence in the coming years. Utilize an FDA-approved systemic therapy. So that's either terbinafine or itraconazole. Can consider fluconazole off-label. Topical therapy, you have cycloperox, you have efinaconazole and taboberol. Recognize that treatment of vascular disease and peripheral neuropathies is challenging, and so we really have to be careful in choosing the right drug for these patients. And finally, to discuss prevention of recurrences. And so I really thank you for your attention, and I look forward to hearing your questions.
Fantastic, Dr. Lipner. Absolutely fantastic. Really great. I'm going to start firing. I'm going to fire away. So if I'm struggling with any of the pronunciations, I'm sure you'll bail me out.
Yeah, go for it. Go for it.
All right. So Dr. Sephoris asked, there may not be any studies showing the benefit of both an oral and topical at the same time. Given how difficult it is to treat onychomycosis, does it make common sense to prescribe both at the same time? Also, would it make sense to continue with a topical after finishing orals such as terbinafine?
Yeah, I think that's a great question, and that's really why we did our review on combination therapy. And so there really was not a clear benefit. I will say that some of the newer drugs, such as efinaconazole and taboberol, really weren't in these combination studies. So it remains to be seen if there is a benefit to using the newer drugs in combination with the orals. But based on our study, we saw very little benefit. So I think, use your best judgment to pick either the best topical or the best oral that you think is appropriate for the patient. See it out. So, do it for a year for the topical, do it for 3 months for the oral, see what happens. And so that's why I use a ton of telemedicine. You can have them send in pictures and you can follow them out, knowing full well how slowly the toenails grow. So my approach is to do one at a time. Really the one exception where I would consider doing combination terbinafine plus efinaconazole is in cases of dermatophytomas, because I find that terbinafine alone doesn't work well for that, but when you do the combination, it certainly can. So dermatophytomas, I think, could deserve combination treatment.
Awesome. Dr. Lee asked, what test do you use for Pseudomonas without getting cross-contaminants?
So I find that the coloration of the nail, so that blue color, is often so characteristic that I can make the diagnosis clinically. But there are a few options if you want to confirm it with a laboratory test. So one of it is just clipping back the nail and using your bacterial swab. I like to dip it in the solution first, running it over the nail bed surface, and often the culture will grow out Pseudomonas. So that's an inexpensive you can do. The other thing you can do is send your clipping to the pathologist, and they can do a gram stain, and often, they can determine if there's Pseudomonas there. And believe it or not, there's now PCR that can detect Pseudomonas as well. So I think there's really 3 options if you don't want to just go with your clinical judgment.
Okay. Dr. Scheer has a couple questions. First one we're going to go with is, what is your preferred dosing for oral fluconazole for both milligrams and weeks?
Okay, so Dr. Gupta, Teacher Gupta in Canada, did a study on this, looking at a trial comparing patients who took 150 weekly, 300 weekly, and 450 weekly. And based on that study, the group that took the 150 weekly was almost as good as 300 and 450. So I just put the patient on the lowest dose, which is the 150, and I had them use it until the nail grows out. And so that's going to be variable, but on average, it'll probably be a year for your average patient with toenail onychomycosis in practice. I like to follow my patients to make sure things are working. So I would give them enough for 3 to 4 months, have them take pictures, follow up with a telemedicine visit in 3 to 4 months. Maybe check a CMP at that point, depending on what their comorbidities are. See if there's a trend of there's positive proximal nail growth. If there is, give them another 3-4 months, repeat it, etc.
Are you seeing any cases of terbinafine resistance for onychomycosis?
Oh wow, that's like my favorite topic. That's like a new topic I'm very interested in, and so. I will admit that I was on an advisory board about 6 months ago, and some people there were kind of bringing up this topic, not so much with onychomycosis, but with tinea corporis. And, because I see more onychomycosis than tinea corporis, I was a little skeptical. And so, but it planted the thought in my mind about terbinafine resistance. And in patients that fail terbinafine, that I've confirmed the diagnosis, I know they have onychomycosis. In some cases, I even know they have T. rubrum, and they fail terbinafine, and I don't even understand why. I've been sending testing for terbinafine resistance, and I'm not saying every patient who fails it has mutations, but I'd say about 80% of the patients who fail terbinafine wind up being terbinafine resistant. So I think that this is definitely a problem. And I think this is something we're going to be seeing more of. And I think there's a lot of reasons for this. And I think, number one, there's all these antifungals just in the shelf of CVS and Rite Aid and on Amazon that, everyone thinks they have a fungal infection, and it could be eczema, dishydrosis, et cetera, psoriasis. Patients just think they have fungus, and they're just, they're smearing it all over. This is contributing to antifungal resistance. And the other problem is, there was a paper in JAMA Dermatology a few years ago at this point where it was very controversial, but basically the author said it's cheaper to just give terbinafine to everyone with anyone who looks like they have toenail onychomycosis, rather than testing, because it's cheaper to do it. And so I don't know if that had an effect on anyone, but I don't know. I thought that was quite inflammatory, and I think that could be contributing to terbinafine resistance. Myself and another nail person, Dr. Bonnie Lucy, also wrote letters about that. And then Aditya Gupta wrote a paper basically proving that it is cost effective to test for onychomycosis. So I think it's a problem, and I think it could become even a bigger problem, if we don't do something about it. And I'm working with the CDC now, on how to study this and how to do something about it. So hopefully we can stop it before it gets out of control.
How often do you diagnose or treat nails with microtrauma?
You're saying nails that are sort of traumatic and then have onychomycosis, or just trauma in general?
I don't know, Dr. Sher. Maybe you want to clarify that question while we move on to do you use lasers for onychomycosis?
So I did use some lasers when I was first starting out. And so I have some experience, with it. And so I will say that the patients I treated, it was very, very, very painful. I used the Nd:YAG. It was really painful for them. And I even used EMLA and such. So, I did get some pretty good results in some patients. I don't have long-term follow-up on them. But the studies that Aditya Gupta showed, they weren't great studies is the problem. They weren't great studies. They weren't followed out long-term. And so we don't know what happened with the patients. So my general recommendation is not to use lasers. I think we have better options.
Okay. Pulse dosing oral terbinafine appears to provide equal results. Do you concur?
There are some studies that show that. I don't see really any major adverse effects with continuous dosing. So my regular regimen is to use continuous dosing. Occasionally I have patients that are just very adamant that they want pulse dosing because someone told them about it, and so they think it's somehow safer. And so occasionally I have done it. But because I think the safety profile of terbinafine with continuous is very good. And because the studies on continuous dosing are larger than the pulse dosing, I use continuous. But I think you are supported if you want to do pulse.
Okay. Dr. McLean asked, with the use of a topical, what is the importance of reduction of the dystrophic nail?
Yeah. So, I mean, generally, I put up a table showing who should and who shouldn't get topicals. And so, if there are no contraindications and someone has a nail thickness more than 2 millimeters, I would say go for an oral. If the patient has contraindications to terbinafine or itraconazole or fluconazole, and you must give a topical, I would say here's where I think some of the debridement is really important. And so I don't do debridement. I'm a dermatologist, but if I have a patient who I think needs a topical and I can't give them an oral, I work in conjunction with a podiatrist and we treat the patient together. So yes, I think you do have to reduce the load.
Awesome. What is your treatment? Dr. Kurlansky asked, what is your treatment choice for saprophytes?
So it's a great question. I wish I had a lot of data to share with you, but the bottom line is that there are very few studies on the non-dermatophyte molds. And so if you read these studies, they say that they had 8 patients with, various different saprophytes. And so there's just such not good data there. My general plan is I start with terbinafine, and sometimes it works and sometimes it doesn't. And if they fail, then I would probably go to itraconazole. And if they had a contraindication to itraconazole, because there's 1 gazillion drug-drug interactions, I would probably go from terbinafine to efinaconazole solution. I will say that I think you have to be careful with the non-dermatophytes. I think sometimes they're contaminants. I think sometimes they're not real. And so, if I, let's say, have both a culture and a PCR both showing a non-dermatophyte, or I have 2 separate culture, 2 PCRs, I'll probably believe it. But if I just get one, I may choose to repeat either the culture or the PCR, because I think there definitely can be some saprophyte contaminants there.
Okay. Dr. Maglia, what is your protocol for daily application of topical antifungal meds for prevention after successful treatment?
So I don't use the topical nail antifungals. I think they're expensive. I think there isn't a single study that has looked at it. And so I don't think there's really evidence to support using these drugs to the nail. But what I do is I'll give them, let's say a big tube of econazole cream, 85 grams and 100 refills. And I'll tell them to apply it every day to their plantar feet and their interweb spaces. And I think that it gives me great success. I see very few recurrences. And the reason I do it is from the Schemmer paper that I just quoted. And in that paper, the patients were only doing it once a week. And look, that may be sufficient, but I feel that if I tell a patient to do it once, if you told me to do something once a week, I would probably just completely forget to do it. If you told me to do something every day, maybe I would get five nights in, and that's probably more than good enough.
We got the clarification from Dr. Shear. Do you see patients with onychodystrophy as a result of shoe microtrauma or biomechanical toe deformities causing nail pathology?
Oh, absolutely. Absolutely. And so sometimes I think that could be its own thing, or you can also have onychomycosis there. And so if there's microtrauma plus onychomycosis, I think it's important to treat onychomycosis, but also let the patient know that, their nail may have a mycological cure, so the fungus may be gone and it may look somewhat better, but it may not be a perfect looking nail. And then for those patients that don't have onychomycosis, you can do things like referring to, my favorite podiatrist for debridement. I use sometimes urea cream, and as well as something new I'm doing is Keriflux. And so that can give patients, a nice cosmetic approach to it.
Well, I think we're coming to a close, but we're going to end with this one. Dr. Cornelius asked, do you think there's a genetic predisposition to fungal infections?
Also, I have to say all these questions are really great. And so there are some studies showing that there is a genetic component to it. And so I think there is, but I think probably the bigger factor is the patient's environment. Mm-hmm. Because I see these crazy families where there's like a husband, a wife, and 4 kids, and they all have onychomycosis. And so I don't think all of it's genetic. I think maybe for the husband or the wife, it had some genetic basis. And then there's just so much fungal load in the house that they're all just getting it. So yes, but I think we can play a role in treating it and preventing it.
I'll actually give you one more. Dr. Kemper, do you have a cutoff age to give oral terbinafine, or is it just dependent on the liver function and neutrophil tests? And do you only test before prescribing the medication?
Another great question. I don't have an age cutoff. Okay. And so if the patient is 96 and like a fully functional person and there's no contraindications to the terbinafine, I will give it. If it's like a 96-year-old nursing home patient where like the daughter is dragging in the patient and the patient, like, I don't think that's their issue. The onychomycosis is not really their issue. Like, they're so debilitated. I may just give them a topical antifungal to the feet to prevent the nails from getting worse. So I don't have an age cutoff. I think all patients, regardless of their age, if they want to treat their toenail fungus, they deserve to have, great looking nails.
Dr. Lipner, absolutely a pleasure. I look forward to working with you again. We had some tremendous questions. If there's anything else that comes up, I'll try to get those funneled over to you so, they can be answered. I think we covered mostly everything. I just want to mention everybody that's still here, over 330 of you still in the room, which is fantastic. We did put up a short survey. Click on that. Just let us know how everybody did, all the speakers, the event, everything like that. A quick mention on CME. We tabulate all the attendance records. We provide those, and then you'll receive your CME certificate via email and mail as well within the next couple of weeks. Once again, Dr. Lipner, absolutely a pleasure. Thank you, everybody, for being here. Thanks again to Bako DX for the unrestricted educational grant in supporting the CME online event. And thank you for the 350 plus attendees today. That was really spectacular, a spectacular event all around. And I think that's it. All right. Have a good one. Enjoy the rest of your Saturday.